Welcome. I would like to introduce today David Mckenna, who is a crucial part of our team in management of the cancer of the prostate and in investigating the disease of the prostate prior to surgery and prior to surgical treatment that we do perform at our centre. I would welcome David.
Thanks.
Very good to see you.
Thank you very much.
This meeting we hold fairly frequently, once a week in fact, when we discuss our cases.
That's right.
And I would like to pass on now the word to David, and he can talk about the MRI of the prostate and the cases that we have gathered for the last week, so that we can look at prior to going to surgery.
That's right. Look, we have a meeting every week and we discuss a lot of the routine cases, and then occasionally we get difficult cases which often they can be lost in the report. It's often easier to talk about the patients with Hodo, and Hodo can voice his concerns and I can point exactly and say or identify the areas that I'm worried about. There's really three areas where I think MRI can be very helpful. First of all, patients with a rising PSA, where there's a high clinical suspicion for prostate cancer, but yet the biopsies have come back negative. We've had a few of those.
We had a few of those, David, haven't we?
And we've been able to target areas where we would do additional biopsies.
That's right.
And we'd saturate those areas, and some of those have come back positive.
At least it gives us a good target then, because
Exactly.
because we can have a look at the area that is suspicious when we discuss it together on the MRI, and then we can, instead of doing the blind biopsy, then we can target our biopsies to that area.
That's right,
which really helps.
And I've accompanied Hodo to theatre for the biopsies, and
Yes.
we've discussed the images in theatre.
That's right.
Immediately prior to the biopsy.
Yes, and we all also when we do them in theatre, we often look at the images up on the screen and then correlate those images with the biopsies that we're taking under the ultrasound guidance. And that has been very helpful.
And then the second scenario where MRI is very helpful is preoperatively, where we're looking to localize the disease and also assess the volume of disease, and look at the adjacent structures, see if the amount of prostate cancer is localized specifically just to the prostate gland.
Yes.
And we've had a few cases again that we've discussed where unfortunately the disease is extended outside the prostate.
Yes.
And that's change management.
Yes. In fact, as you pointed out, David, it's very important because when we get the pathology back, often we find that, for example, there's cancers that are 0.5 millimeters in diameter that are picked, and that's where the volume of disease is very important, because with the MRI will actually give us, like often when you do the measurements, for example, the hypotence area on the MRI is 1 centimeter.
That's right.
So compared to a report that you get on pathology only 0.5 millimeters, all of a sudden now we have the tip of the iceberg, so
That's
to speak, that we've hit, and we have the actual volume much bigger, and much larger, and obviously those cancers then are significant.
That's right.
And I think really in that scenario, in that subgroup of patients, what we're looking at is to try and minimize the unnecessary surgery in that subgroup of patients.
Indeed.
So we don't really want to do surgery if in fact we can't find anything on the MRI and only 0.5 millimeters. And that subgroup of patients have been very important, because that's the group that we can do watchful waiting.
Okay, very good.
So that's where
right.
we've had very good success, I think, in that regard.
And I've also found, and then the third group, I think the last group, was patients who've had, there's a clinical suspicion for recurrence.
That's
and
right.
When we've assessed the surgical bed,
Yes.
you can see if there's soft tissue there. And the spectroscopy can be very helpful.
Yes.
If we see prostate metabolites, it would suggest that it's not just scar tissue. It may represent recurrent prostate cancer in the surgical bed, and that's been very helpful as well.
Absolutely. I think there's been a few of the cases. I think there's been probably 2 or 3 of them that we've had together.
Yeah.
And that in these situations where, for example, the treatment has been done 4 or 5 years ago,
Exactly.
and there's been a possibility of a bit of tissue growing, I think not only does it show us that there's prostate tissue, like you mentioned, but
That's
also it shows that there's cancer tissue.
That's right. That's
There's
right.
cancer tissue. So that's the importance really in that subgroup, because you want to know, is it worthwhile having radiotherapy
Yeah.
in that group of patients? And obviously it always is, because that group of patients will do very well with radiotherapy,
Okay.
because it's localized disease, and we know that we have a targeted treatment.
Yeah.
And I think there was one case that we did together where patients has had radiotherapy in the past, and we in fact actually considered that patient for HIFU,
Okay. Very
the
good.
high intensity frequency ultrasound, and actually there was the nodule there that we could identify and actually perform HIFU treatment on it.
Excellent. And then the other thing that I found very helpful is that when we're assessing the prostate gland, obviously the field of view, the images will include the extraprostatic tissue.
Correct.
And that we found some interesting pathologies outside the prostate gland.
Correct.
We often find diverticulosis, which is important, but because we image the prostate gland and also do CT examinations of the abdomen, we've also found synchronous cancers in the bowel.
Correct.
And also in the
Yes.
kidneys.
That's right. That's correct. Because I guess the volume of cancer that we treat here in Canberra is significant, and the coincidental findings of the renal cancers is not uncommon.
That's
not
right.
uncommon, and in those cases, treating both cancers is very important.
That's right.
Because the outcome for the patients long term is much better, because then the kidney cancer also is found at a much earlier stage than it would have been found otherwise. The other interesting cases, for example, like you mentioned before, would be patients that have cancer outside the prostate capsule. So it's very important for us to assess before surgery, can we perform bilateral nerve sparing surgery? I mean,
Exactly.
and for patients that we want to perform bilateral nerve sparing surgery, we want to make sure that we can come safely to the neurovascular bundle and safely very close to the capsule of the prostate, and do the interfascial nerve sparing surgery, which obviously has been has been developed and promoted in the United States as the best form of nerve sparing surgery. And certainly with the MRI, it has really made this possible, because it enables us to see exactly where the capsule is, where is neurovascular bundle, and how far from the neurovascular bundle is the actual tumor. And often we can then tailor the surgery to the patient. So this is the aim of the MRI, is really tailoring the surgery to that particular patient. Because we have to make sure that can we offer the nerve sparing surgery safely, the volume of the disease that we are assessing, how close is that disease to the neurovascular bundle, and also is there a lot of extracapsular extension. I mean, small amount of or doubtful amount of extracapsular extension can still be treated with surgery. However, one particular case comes to mind very recently, actually, that you had a look, and we had a look at it. It was a couple of weeks ago that we did,
That's right.
and where we actually saw that the tumor went far beyond the prostate, locally invasive, and surgery would not have been an appropriate treatment in that group of patients.
Correct. And actually, funny you should mention that. I'm aware of literature which shows that the degree of extracapsular extension has a long-term prognosis on the patient, and that's with regard to radiotherapy. So documenting these findings is very important, not only for counselling but also for prognosis.
Very, very, very much so. And as you pointed out, I think it's important that we're not only looking at surgical treatment, we are looking at holistic treatment.
Exactly.
We are looking at radiotherapy, we're looking at high-dose radiotherapy and the surgery, and which is the most appropriate treatment for that individual patient.